All right, we got a 76-year-old Caucasian male. He comes into my practice and he says just straight up, I have cataracts, take them out. I expect to stay glasses free. And I had LASIK surgery and I want to be exactly like I was when I had LASIK surgery. Oh, by the way, I have a little bit of glaucoma. And oh, by the way, send me all of your consents, all your patient education materials. I need to have my attorney review it all. This was our first interaction. We didn't touch the guy yet. This was our first interaction. So immediately when this guy comes in, I'm just kind of guard up. Holy cow, this is you're coming in flames are burning here, man. This is not usually how I like to discuss cataract surgery. I don't like to discuss cutting open your eyeball if you're already talking about bringing in the attorney. Um, so we kind of went back and forth. I mean, how do you guys handle this? Do you guys immediately, no go when you have these sort of interactions?
I mean, I think I'd address it head on and just sort of, tell them I got to take a step back and there has to be a trust relationship because if you don't have that, maybe it's not the best fit. I think, you can either back off or you can go head on, and I think I'd probably confront that one. What about you guys?
Yeah, I'd probably send over the consents, education material, have the patient come back in for a pre-op, go over any questions he's got, and ask if the attorney had any unique questions, and probably say, I think we should probably see you back in about 6 months.
Or find your least favorite referring office.
Yeah.
Pass
How
it
about you,
along, right?
Bobby?
Share the
Yeah,
love.
I mean, not real excited about this first interaction. But yeah, have the attorney come to the next appointment and let's list what our goals are in a perfect scenario and then talk about if we can get those or not. Especially, wanting to stay glasses free in somebody who's had LASIK and has a little bit of glaucoma. So, I mean, yeah, send over the consents. Let's talk about those. Glaucoma, what's our definition of glaucoma? Mild, moderate, severe? We're talking about open angle or closed angle. And then what type of LASIK do they have? I mean, was it myopic LASIK, a little bit of myopic, lots of myopic LASIK, a little bit of hyperopic, lots of hyperopic LASIK, just so we can figure out what kind of expectations we can set for the patient.
Yeah, I don't really shy away from confrontation in refractive surgery. I mean, I think you all know as well as I do that refractive surgery is as much psychology as it is math and science, and you kind of have to know how to negotiate with your patients. And so I don't really shy away from that. We did talk about it, and we kind of went back and forth a little bit, and we basically took the average of all of your guys' approaches and went with that. And we decided that we're going to go ahead and proceed. Here's his exam. So his pressure 14. He was on double therapy. He was taking Lumigan QHS. He was taking Dorzolamide BID. Don't know what his Tmax was. We really don't have a whole lot of a history. He didn't really bring it with him, and he wasn't really helpful. He was just basically a you guys figure it out kind of dude. And so we're like, okay, we'll do the best we can. Exam LASIK scars. It was a mild myopic LASIK. I'll show you the pentacams here in a little bit. He was pretty dry. 1 plus SBK inferior, very unstable tear film. Good open angles, 3 plus NS, and he also had a little bit of mild maculopathy. Nothing really concerning, but there was definitely some pigment modeling at the macula. So his pentacams look like this. Kind of tough, that's a lot of dryness on his pentacam. We took a couple different scans, and they all looked very similar, very irregular. A little bit of a myopic treatment, a little bit of cylinder on the left eye there as well.
Mhm.
Nothing too aggressive. His right eye was definitely more aggressive than the left eye. You can tell by the thickness in the corneas. There's his retinas. A little bit of modeling. It's not really clear on the OCT, but there was some dry punctate drusen. Again, nothing visually significant. And there's his nerves. So his nerves are showing some thinning in the superior and inferior rim, both eyes. And again, before I show you the next step, any concerns, any thoughts with how to proceed with this patient?
Anu, what are your thoughts on the glaucoma part of this? Just looking so far, I know we don't have a ton, but
Yeah, well, I mean, I think that the key thing is that we often will look at an OCT and immediately have some thoughts, but really you don't stage on an OCT, you stage on a visual field. So we actually don't know at this point. So it's actually, it could go either way. So I would reserve judgment until I see the visual field there. But I agree about the macula. Not a whole lot to write home about there, but it's not perfect.
yeah, I think that the corneal topography actually for me, it's like, yeah, there's some dryness there, but like seen a lot worse. So, For me here, like overall, I'm like, I think I can work with these. I'm not even throwing it like if it looked like this, like I would even maybe even consider putting a trifocal in if we had the right expectations. If you go to the next scan, I think the MAC OCT, like sure there's a little bit of maculopathy, but overall like that looks good. And then looking at the OCT of the nerve, I think one key thing to remember in glaucoma is it usually infects inferior temporal and superior temporal. And we see some potential thinning there, inferior temporal and superior temporal. So it's like, okay, so it probably is glaucoma. But like you said, Anu, let's check out the visual field, check the staging of it, and then that will probably determine if a patient is trying to get distance and up close vision. Do we go a multifocal route or do we do something like the light adjustable lens?
Yeah, I mean, up until this point, I was thinking we could really do a lot of things. I might be a little bit less inclined to do a full bifocal or trifocal IOL. I mean, like a panoptics, possibly a Vivity. This is a patient from a couple of years ago, but I might consider doing an Odyssey at this point. Again, this was 2 years ago, so the Odyssey wasn't really around. But Vivity would have been something that I would have considered until I saw the visual field, which he again was staged, quote, a little bit. So this was his a little bit of glaucoma. Now, what do you think? Are you thinking that we could do an EDOF IOL? You think we could do a multifocal IOL? Are you thinking because we have a prickly patient who's already threatening legal action, is this somebody that you're going to punt as far down the road as you can to your favorite optometrist or ophthalmologist in the county over?
Well, I
Becky,
would
what's
definitely
you?
not be thinking about a kind of a presbyopia correcting option here. I think
Yeah.
better to keep it simple. You got some central loss there, so by definition, that is kind of edging into that advanced territory. Thankfully, your most of your loss is superior as opposed to inferior, and so that's functionally that's good news for the patient. But down the line, this patient's still only in their early 70s, if I remember right, and so you got some runway to go there. For me and our practice, I think this would be a good quality monofocal or monofocal plus lens, like an Eye perhaps, or a Raynor EMV, something like that, where you get a little bit of bang for your buck. But it's really expectation management for me. The gravy on top here, I think, would be kind of a combined MIG surgery, angle-based surgery. You're going into the eye, the patient's on two classes of meds. They do seem to be quite high maintenance, and maybe if you can offer them maybe not that full range of vision, but maybe you can, reduce their drop load. I think maybe that might go a long way to, helping that ocular surface as well, stabilizing the vision, maximizing what they have.
Becky, what about you?
Yeah, I
Any
really
thoughts?
agree. I think this would be a great patient for a combined MIGS procedure. Be really interested in an EMV or an IHance in a patient like this. In some of those cases, we'll do a little bit of an offset, a blend. I would not recommend that I wouldn't be comfortable doing it in a patient like this. So I'd be very clear, again, on expectations, planning for best distance, maybe a little bit of kind of computer range, but you'll have glasses for small details up close and end of the day computer work expectations on that. LA would be interesting. I mean, they appear to have fixation. I don't know. I mean, you could go LAL in this, but I feel like with a patient personality that started off, I don't know that that patient's going to be interested in the long-term uh, process of LAL.
For me, I think that I like these kinds of patients. I like LAL because like they get to choose where they want to go because like maybe they want to be nearsighted in both eyes because that's where their world is and they're okay wearing glasses for far away while driving or maybe they don't drive. I mean, I feel like every patient is different. So like I still feel like LAL could be an option here because maybe while we all want distance vision or maybe a little bit of a blend, like I feel like every patient is different and I'm really interested to see what you decided to do here, Nick.
Yeah, I mean, the LAL is really the only thing we were considering, honestly, in this patient. And by the way, here's his progressive fields. He's been stable. He did bring those with us. This was the only piece of information we had, but he has been pretty stable over the last couple of years. So yeah, we did an LAL and we ended up doing a KDB. So we did a goniotomy, so an angle-based procedure to also relieve his drop burden. We picked the LAL because if you think about, an Eyehance or an EMV, these are both aspheric, they're monofocal plus lenses, which really the LAL is also an aspheric, and it could be considered in its natural state a monofocal plus, kind of in the same category. Plus, you get the ability to manipulate and adjust the lens to match the patient's goal. We got a picky patient here. We know that he's got expectations. I don't shy away from confrontation. That's the psychology of this space. And so I'm confident once we kind of came to terms with our what our expectations are realistically going to be, that I could get this patient what he's looking for And, we could meet what he wants and really achieve a pretty comfortable outcome. So we ended up going LAL and really happy we did. We ended up doing plano in the right eye, and we ended up doing a little bit of a blend in his left eye, targeting ultimately -1.5. Now, with the light adjustable lens, one thing you can do is you can induce added negative asphericity in the non-dominant eye. And there's some specific ways to do that during the light adjustment process. In this patient, I definitely did not, and I would not recommend doing that because you've already got a patient with compromised contrast sensitivity without a doubt on the visual field. If you induce added negative asphericity, which is there as an opportunity to enhance depth of focus, what you would be doing is reducing contrast sensitivity potentially further in a patient who already is losing some. And that's something that you can't undo. So in this patient, I did not and I would not do that. Now, we ended up getting a great outcome. He was 20/20 in the right eye. He was correctable to 20/20 in the left eye, and he ended up -1.25. Pressures were 12 and 12. He still was on the drops. We did, being a severe glaucoma patient like he was, we want his pressure as low as we could, ideally 10 or lower, or close to 10. And, we're getting him down, but not a comfortable spot where I would really want to take him off his drops just with that severe vision loss. So and he was okay with that. But we did avoid having to add a second drop or a third drop in this case. So the funny thing about the light adjustable lens that I've kind of learned over the last few years is these patients that you want to get rid of, well, now they're your patients forever. This is my patient. I see him 3 times every year because I made him happy and he just keeps coming back. That's something that this lens will do for you. So any final thoughts? The glaucoma expert here. Any thoughts with how we did that, what we did? Would you recommend maybe trying to discontinue a drop?
No, I agree with you because of kind of where he ended up there. I mean, we don't do a whole ton of KDB, but I mean, with your angle-based procedures, you've got a lot of different options. Goniotomy is great for that. The patient was open angle too, so you're not so much worried about your underlying TM dysfunction as well. So that is helpful there. It is really interesting to me, and I almost wonder, did you repeat the fields afterwards? Just because it's interesting with a patient with 3 plus NS, and they had 20/20 and I think 20/25 or something BCVA pre-op.
Mhm.
So I almost wonder, like, were we off on our staging there a little bit or something? Or maybe it wasn't as bad as we thought. Maybe things were a little bit more optimistic. But I agree with the management. I think that's great. Keep them on the drops. We would do kind of a combined drop, but if they're already on it, tolerating it well, I think that's a great approach.
That's about it. Yeah, we have done serial fields after, and it's pretty consistent.
Yeah.
He's severe. He's missing half his field of vision.
Yeah, and I would still say, like, even though he's on drops, things are more stable. You don't get that diurnal variation. I mean, we do like our eye care home tonometries and things like that, and it's, proof is in the pudding there that you do get that kind of stability. So even though the numbers may be not that far off, I think that's ultimately doing the patient a huge service in addition to their cataract and their refractive outcome. And hopefully he referred his attorney to you for his 3 times a year as well.
We have not gotten sued yet.
Goodness.
Knock on wood.